Thank you. So welcome, everyone. My name is Courtney Finlayson. I am a pediatric endocrinologist at Lurie Children's in Chicago, and I am the co-chair of the Non-Oncologic subcommittee of the Oncofertility Consortium. So in that role, our subcommittee is hosting this webinar about Klinefelter syndrome. And I think that you are all in for a treat today because we have two international experts who've joined us today. So it's good evening to them. So we have, I will start out by talking a little bit about Klinefelter syndrome in the prenatal, infant, pediatric period of life. And then I will hand it over to Dr. Claus Gravholt, who is an adult endocrinologist in Aarhus, Denmark. And then we will hand it over to Dr. Ellen Goossens, who is a professor of biological sciences and an expert in testis and fertility preservation in Brussels, Belgium. So we will start. So I will go ahead and get started. And this is Lurie Children's. I figured since we have the world tour here of people, I'd show you where I am. And it doesn't look quite this pretty. It looks cold and snowy and slushy and icky right now. But for the pediatrics portion of this, I'm going to talk a little bit about diagnosis of Klinefelter syndrome and the changing landscape due to prenatal diagnosis. And then we'll talk about reproductive hormones in infants, childhood, and adolescents. So the diagnosis of Klinefelter syndrome is an interesting topic right now. So overall, when you think about the incidence of sex chromosome aneuploidy, it's estimated to be about 1 in 400 in the United States. And that incorporates conditions other than Klinefelter syndrome. But the incidence of Klinefelter syndrome is thought to be around 1 in 600 male newborns. It may be slightly more frequent than that. There was a study in the 1990s which estimated or which sort of looked at how often is Klinefelter syndrome diagnosed and at what period in life. And in that study, they found that about 10% of the time it was diagnosed prenatally, 7% of the time in childhood or adolescence, 17% of the time in adulthood. And it was thought that about 66% of the time it was never diagnosed. All that has changed a lot. And it's certainly been diagnosed more often than that since the 90s, but non-invasive prenatal testing is changing this landscape significantly. So non-invasive prenatal testing is done for sex chromosome aneuploidy. In 2011, this became commercially available in the United States. And in 2016, the American College of Obstetrics and Gynecology stated that all women should be offered the option to have non-invasive prenatal testing. And so it's thought that this has increased the diagnosis of all sex chromosome aneuploidy from about 10% to 75 to 100%. So that means that we're seeing maybe 5, 7, 10 times the number of diagnoses early in life. And it's also possible that the rate of Klinefelter syndrome or sex chromosome aneuploidy may be increasing due to rising maternal age and the increased rate of non-disjunction that you see at that time. So with this information, I'll just show you, this was data from our own clinic about a year ago in terms of the age groups that when we tend to diagnose the Klinefelter syndrome. So we see the biggest group in our population in the prenatal and infant periods. And that's really due to this increase in non-invasive prenatal testing. And then we get another jump in early childhood as kids are having testing related to developmental delays. And then again in adolescence. So it's more than the fact that we're just diagnosing this more. It's really changing what we can learn about Klinefelter syndrome. So previous studies always had a significant ascertainment bias, and many still do. But because people were diagnosed because they had a developmental delay or because they presented with testicular insufficiency. But now, in theory, we're just diagnosing everybody who has this with prenatal testing. So that really changes the ability to study the population and to really understand the natural history of this condition. So the Extraordinary Baby Study is being done at the University of Colorado, and it's really quite amazing. They're enrolling infants 2 to 12 months old with a prenatal diagnosis of sex chromosome trisomy. So this is including more than just the boys with Klinefelter syndrome. You might also have XYY and some other conditions like XXX. But they're comparing the natural history, identifying predictors of positive and negative outcomes, developmental and autism screening, and they're really building a very rich data set. So they see the participants at 2 months, 6 months, 12 months, and then annually. So they're collecting data about, all of these different things, demographic and family information, development, and then there's medical data and biological samples for biorepository. So they have started to present some of their findings, but a lot is yet to come in this study. I'm going to focus on some of the things most related to reproductive hormones. So the first period of time that we can measure reproductive hormones in babies is in this mini puberty. And so there are some studies which have evaluated mini puberty in Klinefelter syndrome. And this shows a number of them. And on the bottom, you see all these different studies, and then the testosterone levels that they found in the subjects that they examined. So they range from having 10 participants to having 87 or to having 38, but there's 87 when you put these all together. So all combined, it seems that in the mini puberty, when we expect boys to have a surge in testosterone levels, that boys with Klinefelter syndrome do still have a mini puberty. They do still have a surge in testosterone levels. However, it tends to be lower than the median for boys who do not have Klinefelter syndrome. And some are truly below the lower limit of normal. So there's been a question of whether there is value of giving testosterone to infants in terms of whether this would assist in many different aspects of their development and both behavioral, motor development, whether this would have any physiologic benefit. And so this initial study by Shanley Davis at University of Colorado, they had 20 infants, 6 to 15 weeks old. They gave testosterone 25 milligrams IM monthly for 3 months. And the outcomes that they were examining were, the primary outcome was looking for a change in percent fat mass score, and secondary or other aspects of body fat composition. And then they also looked at linear growth, so actual length of the baby, and then stretched penile length. And in these, for their primary outcome, they did find that there was, you can see in the first graph with the one on the left, that was the no testosterone group. And then the one on the left is the one just next to that bar. You can see that there was a decrease in the percent fat mass in those that received testosterone. In the other aspects, they also changed the change in mass. They saw that the testosterone group had an increase in mass, a decrease in fat mass. And then in the bottom two, you can see that actually the group that received testosterone had longer length. So they had more linear growth, and they had more growth in stretched penile length. This is the final thing that compares typical female, typical male, and then the Klinefelter syndrome who received no testosterone versus those who did receive testosterone. And again, showing that percent of fat mass at 5 months age was lower in those that received testosterone as opposed to those who didn't. And it was much more comparable to those of a typical male infant. So the next phase of this is a double-blind randomized control trial comparing testosterone and placebo with crossover. And Dr. Davis reported this at the 2022 International Klinefelter Syndrome Consortium. And she said that there were 71 infants. They had a few posters at that consortium, but there were 71 infants. They showed an increase in penile length with testosterone treatment, but at least in the initial evaluation, there was no short-term impact on neurodevelopment. Because the thought was maybe if their fat mass, if they have more lean body mass, maybe that's going to help with motor development and some of the motor delays that you can see in these kids. But at least at that point, it was not showing, they did not see those results. There were minimal side effects. I mean, they saw more erections in these babies, a little bit of pubic hair, but we're all waiting for the rest of their results to be published over time. The next period of time we think about is this childhood period, and there have been questions about whether replacing testosterone in childhood would be of value. So there is a study that examined 84 boys, 4 to 12 years old, and gave oxandrolone as it's a relatively weak androgen. It acts at the androgen receptor, but it's less virilizing, less hepatotoxic, and it's not aromatizable. So that's why that was used rather than testosterone itself. And it was given for 24 months. And the primary outcome was to evaluate motor function and strength, and then others were about cognitive function and language, memory, attention, executive functioning, and social functioning. And they would decrease the drug dose if they saw increase in HDL or advancement of bone age. And in terms of their primary outcome, they did see that the visual motor skills were improved in those who received oxandrolone versus a placebo, but they did not see a difference in some of these other primary outcomes. In terms of secondary outcomes, they did see some improvement in anxiety, depression, and social functioning. They did not see any difference in general cognition, verbal skills, or working memory. They did, however, see that there was earlier gonadarchy in those who were treated with oxandrolone versus a placebo. So they saw that testicular size increased at about 9.8 years, plus or minus a year and a half in those treated versus 12, plus or minus 1 in those who were not. They did not at that 2-year mark see a difference in hormone levels, but they didn't follow past 2 years, so they don't actually know about how this may have affected puberty ultimately in terms of adult height, fertility, or other aspects related to potentially having early puberty. So with this information, they recommended caution in treating prepubertal boys due to the risk of precocious puberty. And as a side note myself, I usually think of this as, typically, particularly at least 4 to 9-year-old boys are not typically going through puberty. So this would not typically be a time that you would expect boys to be producing or being exposed to testosterone. So as a pediatric endocrinologist, I think it gives me a lot of pause to think about treating at this time, although I do know that some of the issues related to motor strength and certainly anxiety, depression, social functioning are really important for these boys. If we move toward adolescence, you see that what we expect for boys with Klinefelter syndrome is that they will start puberty typically at the time they probably normally would have. And testicular size will increase a little bit, but then it will usually regress and testicular size will remain small. So this graph shows testicular volume from about 6 to 14, 16 years old, where you can see that it remains much less than what you would expect, and it stays that way in adulthood. I'm not going to talk too much about this, but if we were looking inside the testicles, you would also see that from the fetal period in the top left to the 14-year-old, there is a progressive loss of germ cells during this time period. And then if you look at their hormone levels, you'll see that testosterone again starts to increase in puberty, but typically then decreases and may be in actually low or in the low normal range. LH rises in puberty and stays high, and FSH does as well. So when we're seeing adolescence, typically we allow puberty to start, but then we do start to evaluate gonadal function. And most adolescents will develop testicular insufficiency, and you need to consider starting testosterone replacement. Dr. Gravholt will talk more about that, and the benefits of testosterone and the controversy about when to start testosterone replacement. And then it's important, and I always am talking to teenage boys about how Klinefelter syndrome will affect their fertility, and at least having a discussion about how what this will be, and considering, there's a lot of debate about fertility preservation in adolescence, but at least having some conversations about that. at that time. And I will leave the rest of those discussions to the experts that you will hear from next. And I meant to say this at the beginning, but we will all go ahead and talk, and then we'll have time for questions at the end.
Okay, thank you, Courtney. And I will move on from here and talk about Klinefelter syndrome, mainly during adulthood, but I will actually start out by talking about genomics, because there are some very, very interesting results coming out of several groups around the world these days. And we'll move head on into the thinking that we have right now. So we're going to implicate Turner syndrome as well, because as you know, in Turner syndrome, we have only one X chromosome, and in Klinefelter syndrome, we have 3 sex chromosomes. And in fact, these two syndromes share a lot of commonalities. For instance, there are problems with fertility, hypergonadotropic hypogonadism. There are issues with increased risk of diabetes, metabolic problems, the cardiac system, not to the same extent as you know, but still there are several shared traits. And current hypotheses are that the syndromes result from the imbalance of expression of genes within the pseudo-autosomal regions of the sex chromosomes. So here you see the two pseudo-autosomal regions, PAR1 and PAR2, and especially the genes in PAR1 and the homologous X and Y chromosome genes that escape X inactivation in females are also of interest. And in this recent study that we published, we studied both Turner's and Klinefelter's along with matched female and male controls. And we sampled both blood, but also fat and muscle in the same individuals. And doing that, we could see that a number of X chromosomally expressed genes were expressed differentially, not only in Turner's and Klinefelter's, but also when we compared them to both males and females. And you can see a list here of some of these genes and that were differentially expressed, and you will recognize, for instance, the exist gene, which is, of course, implicated in X chromosome inactivation, as is JPX and TSIX as well. And they are, of course, differentially expressed in these conditions. There's also a long list of other genes, as you can see here. And these genes have been implicated not just in this study from us, but also in other studies from other groups around the world, and they seem to play a role. We just can't get a handle on how they act, but it's quite probable that these PAR1 genes, but also these homologous genes are of interest in both Turner and Klinefelter syndrome. And when we also looked at not only on X chromosomally expressed genes, but also autosomally expressed genes, these data show us that there are a wide range of autosomally expressed genes that are also expressed differentially in the contrast between Turner's and females, but also between Klinefelter's and males. And these genes may lead us to understand different components of the syndromes, for instance, related to the testicular function, but also to other functions that are not normal in these syndromes. We also looked at methylation data, and here we could see that methylation is also implicated and is differently implicated in different organs. So here you again see blood, fat, and muscle, and you can see that there are differences between Turner's and Klinefelter's, but also between their controls. And these differences are not similar in these different tissues. Therefore, we think that in the future, we need to also not only study blood, but also study the relevant tissues. So you could here, you would like to add testes, for example, but you'd also like to add the brain. But as you know, it's really difficult to get biopsies from these regions. So the genetics or the genomics, I may say, in both Turner and Klinefelter syndrome is getting much more complex. So the extra X in Klinefelter syndrome likely, or we can say that with certainty now, affects the epigenetics, also affects the expression, and this is organ specific, and it also affects proteins. I haven't shown that here, but we know that as well. And likely we will then be able to understand and explain the different phenotypic traits that we see in Klinefelter syndrome. And I think that we in the coming years will come to understand why, for instance, do the testes stop growing, and why do they not produce much sperm, and so on, and testosterone, and so on. But then I'll turn to talk about mortality, morbidity, and testosterone replacement therapy during adulthood. And one of the things that we've seen from large epidemiological studies, both in the UK and in Sweden and in my country, in Denmark, is that mortality is increased with a hazard ratio of about 1.9, which corresponds to a median loss of about 5.6 years. And these data are all based on the diagnosed proportion of Klinefelters. As Courtney alluded to, we're now seeing a surge of kids being diagnosed much earlier than we did with the data that we see in these epidemiological studies. But we can see that Klinefelters die from a multitude of different conditions, and therefore we also need to be alert of these different conditions during adulthood. We could also note here in this study that the hazard ratio is much higher before the age of 15, meaning that a lot of kids actually do die from Klinefelter syndrome, at least in comparison with other kids. And as you know, bone metabolism is one of the worries, and we know that 5 to 10% of Klinefelters will develop osteoporosis with fractures and so on. And these are just data showing you from an HR PQCT study that there are many differences when you look at the bone architecture compared with a normal control group. We also know that the risk of venous thromboembolism and lung embolia is much increased in Klinefelters. And this is really not explained, but we see all the studies that are out there show a 5 to 8-fold increased risk of venous thromboembolism. And for many years, we thought that this was perhaps due to testosterone treatment. Nowadays, we think that this is actually not true, and we looked at some Danish epidemiological data, and here we could see that when we looked at medication among Klinefelters, you can see here that many Klinefelters receive anticoagulation therapy, platelet inhibitors, statins, antihypertensives, and antidiabetics, compared with a normal male background population. And this was due to increased risk of comorbidity due to a lot of different conditions like atrial arrhythmia, hypertension, diabetes, and hypercholesterolemia, and so on. And again, where is testosterone? Is that playing a role here? We thought that it might explain some of the increased risk of venous thromboembolism, but today I don't think that is the case. Again, here we can see that there was about a 4-fold risk in this study of VTE. But when we looked at the proportion of Klinefelters that were actually treated with testosterone, first we could see here that the risk of VTE was much increased compared with the background population. When we then looked at the treated and the untreated Klinefelter population, we could see that not only did the untreated population have a higher risk of VTE, but it also occurred much earlier than in the treated population here. It was not statistically significantly different, but we have performed clinical studies showing that the coagulation profile actually normalizes during hormone treatment. So we actually think that testosterone may correct some of this coagulation differences that we see. So what kinds of treatment do we use? Well, in my country, we use either Nebido, 1,000 milligrams injected every 9 to 14th week, or different types of gel, as alluded here. And in this study, we looked at all the patients, or some of the patients that we had followed for more than 5 years in the outpatient clinic, and we looked at the effect of either a gel or a injection therapy. There was about 150 patients in this follow-up study, and the age was around 40 years in this study. Then we looked at the different metabolic outcomes, serum testosterone, and so on, when we either gave injection or gel. And this was chosen by the patients themselves, so we were not directing this. This was not a randomized controlled trial. But anyway, we could see that the serum testosterone was similar in the injection and in the gel group. And if we looked at different metabolic parameters here, cholesterols, these were similar in the two groups. Serum FSH and LH was higher in the gel group, and we think that was due to the fact that that there are different pharmacodynamics of gels versus injection therapy. We could also see that testosterone, as I showed here, was quite similar over a long period of time. We could see that hemoglobin, an androgen-responsive parameter, was also similar in the two treatment groups. And then we could also see that not so nicely, but nevertheless, we could see that our population of adult Klinefelters increase their weight as they grow older. And many of our patients, unfortunately, are obese, and this is a real issue in adulthood, while it is normally not an issue during childhood. But and many of our young patients are really slim when we see them the first time, but they progressively become more obese as they age. In this small study, we did an RCT of testosterone, and in this study, we could see that during treatment, there was a reduction in the total abdominal fat by CT, and also intra-abdominal fat by CT. At the same time, we could see that hemoglobin increased during treatment, and insulin-like growth factor also increased. But as you can see here, in the control group, the fat mass was much lower than in the Klinefelters, just telling us that even though we have a similar BMI in controls and Klinefelters, they are normally have much more intra-abdominal fat. We also looked in this epidemiological study on how many adults with Klinefelter are actually treated. And as you can see here, only about 50% of patients receive testosterone replacement, even though we could see that they were actually hypogonadal and should have received testosterone treatment. We don't know what is the reason for this lack of treatment, and we can say that all the patients that we see in the outpatient clinic are actually on testosterone. So it must be some of the other patients seen in other parts of my country that are not being treated. So what can we say about testosterone and efficacy in Klinefelter syndrome? Well, we think that there may be a positive effect on many of the traits that we normally see in Klinefelter syndrome. And as I showed you, we think that we can actually reduce the risk of thrombosis with testosterone treatment. We, of course, also think that we can decrease the risk of osteopenia and type 2 diabetes and so on. Many of these effects have not been proven, and therefore we can't say this with certainty. But we think today that, or we know that testosterone treatment, of course, increases testosterone, hemoglobin, and IGF-1. It reduces fat mass and the risk of developing gynecomastia. It increases muscle mass, and it probably reduces the risk of venous thromboembolism. It may reduce the risk of depression. We have some new data that we are analyzing at the moment, and we hope to publish these soon on this issue. It may improve well-being, and it may decrease the risk of diabetes, which is much increased in adulthood with Klinefelter syndrome. So therefore, we of course recommend appropriate testosterone treatment for patients. So with that, I will leave the word for Ellen, and just to show you some of my collaborators here and the people that, or the foundations that funded the work that we're doing. So thank you for that.
Okay, I guess you'll see my screen now. Thank you, Courtney and Claus, for the first talks. My task is to talk about testis development and fertility potential in patients with Klinefelter syndrome. As you know, Klinefelter patients are characterized by a tall stature, long legs, wide hips, narrow shoulders, and breast development. And they also tend to have fewer hair, and what is of interest to my team, they also have small testes. So Klinefelter syndrome is the most common sex chromosome anomaly. It occurs in 0.1 to 0.2% of all male newborns. And it is also the most frequent genetic cause of infertility, because 15% of azoospermic men that visit the fertility clinic turn out to have the Klinefelter karyotype. Now, male fertility depends on the sperm production and, in fact, on the quality and also on the quantity of sperm production. So before puberty, the tubules contain spermatogonial stem cells and Sertoli cells. And these spermatogonial stem cells are the foundation of spermatogenesis. And from puberty onwards, these cells will start to differentiate and become primary spermatocytes, secondary spermatocytes, spermatids, and ultimately mature spermatozoa. And this you can nicely see in the upper picture, where you see a seminiferous tubule of a man with a normal karyotype. But if you look to the picture below, that shows the testicular tissue of a Klinefelter patient. Here you observe extensive fibrosis and also a loss of germ cells. However, in some of the Klinefelter patients, sperm cells are still produced, but in in limited number of focal areas in the testis. And if that is the case, if sperm is produced, the patients can benefit from testicular sperm extraction, or TZ. In 35% to 50% of the patients, we can find sperm by TZ, and this sperm can then be used in ICSI. But unfortunately, most of the Klinefelter patients don't produce sperm and cannot benefit from TZ. So we asked ourselves a couple of questions. The first question we wanted to get an answer to was, when does the germ cell loss occur? And then, is this germ cell loss related to the onset of fibrosis? If we could answer these two questions, then we could also try to find an answer to the third one. Can Klinefelter patients benefit from fertility preservation? Nowadays, fertility preservation is offered to cancer patients and patients with hematological diseases before they start the chemo or radiotherapy to cure their diseases. Now, you know that chemo or radiotherapy can kill germ cells. So for adults, We can offer semen banking before they start with their cancer treatment. And for young boys who do not produce sperm cells yet, we offer testicular tissue banking in order to preserve the spermatogonial stem cells for later transplantation. And then at the end of this talk, we also want to try to answer the fourth question, which is, what is the karyotype of the germ cells? So let's start with the first question. When do Klinefelter patients lose their germ cells? So as I pointed out in the beginning of this presentation, in adults, spermatozoa can be retrieved by TSA in about half of the patients. We also analyzed the testicular tissue of 27 adult Klinefelter patients for the presence of spermatogonia and ongoing spermatogenesis. And this graph nicely shows that the majority of the Klinefelter patients do not have germ cells at all. Even in the TSA positive group, we often couldn't find germ cells in the histological sections. And this also shows that if spermatogenesis occurs, it is present only in some areas in the testis. And the tissue that we got for histological analysis is of course different from that was used for TSE. And it made us show a different histology. Also important to notice is that in patients who had a negative TSE, we sometimes found areas with focal spermatogenesis. That occurred in 20% of the samples. Next, we wanted to know if the fertility potential or the chance to find spermatozoa was higher at a younger age. And therefore, we split the group of adult patients in 4 groups. So we had a group from 18 to 25 years old, then 26 to 30 years old, 31 to 35 years old, and then patients over 35 years old, with the oldest being 41 years old. But we couldn't find a relation between the age and the successful TSE. However, we could find a relation with the hormone levels. When we looked at the hormonal profile, we saw that TSE was more successful, so more green dots were present when the testosterone levels were higher than 7.5 nanomolars per liter, and LH levels were below 17.5 international units per liter. So next, to try to increase the sperm retrieval rate, we asked patients who were diagnosed at a young age to provide a semen sample during puberty. But the results were very disappointing, since sperm cells could be found in only 5% of the patients. And when we looked at the histology, it was even more surprising that also spermatogonial stem cells were lost in most of the patients. So 70% of the pubertal Klinefelter patients didn't have germ cells anymore. So the next strategy was to check the presence of spermatogonial stem cells at an even younger age. And here we found indeed spermatogonial stem cells in 80% of the boys between 4 and 11 years old. In 20% of these boys, the spermatogonial stem cells were already lost. So you think this might be a good result, but we need to be aware that this graph shows the percentage of patients with germ cells. The next graphs show the results in a slightly different way. So this graph in the middle shows the percentages of seminiferous tubules with germ cells. And here you can see that Klinefelter patients have very few tubules containing germ cells compared to control patients. And this is true for adults, for peripubertal, and also for prepubertal Klinefelter boys. And if you look at the number of germ cells per seminiferous tubule, or number of germ cells per tubule with germ cells, then we see that the few tubules that contain germ cells harbor only very few germ cells. So in the adult Klinefelter patients, it's only 5 germ cells per positive tubule. And this number is similar for pubertal and for prepubertal patients. And then in order to complete the timeline, we also evaluated 5 fetal samples. And here all samples contain spermatogonial stem cells, and the amount of stem cells was comparable to control tissue, at least until 23 weeks of pregnancy. We don't have data after this time point. So all this shows that germ cells are lost at a very early time point, somewhere between halfway pregnancy and early childhood. So it might be during mini-puberty, but this needs to be confirmed. More studies are needed, although it will be very hard to obtain samples from such young Klinefelter boys. And the next question was, is germ cell loss related to the onset of fibrosis? And therefore we scored the testicular tissue from fetal, prepubertal, pubertal, and adult Klinefelter patients according to this table. So a low score means normal tissue, and the higher the score means the more fibrosis and the less seminiferous tubules. In adults, there is a clear difference between the Klinefelter and the control testicular tissue. A lot of fibrosis is observed in Klinefelter patients, and no fibrosis is detected in control tissue. And if also compared to samples from Sertoli cell-only patients with a normal karyotype, we see more fibrosis in Klinefelter patients. Around puberty, fibrosis is already present, but that is not the case before puberty. And similar results were seen when we looked at the tubular integrity. The percentage of normal, degenerated, and hyalinized tubules is shown in this graph. And we see that hyalinized tubules were seen in adult and in pubertal Klinefelter patients, but not before puberty. So to summarize this part of the study, sperm retrieval is successful in 35 to 50% of the adult Klinefelter patients, so they can benefit from TASE and sperm banking. Performing TASE at the onset of puberty does not improve sperm retrieval rate. So testicular tissue banking to preserve spermatogonial stem cells is also not an option, because at this age, most of the germ cells have already been lost. The germ cells are already lost before puberty, so also for these boys, testicular tissue banking is not really an option. We also saw fibrosis, and this is initiated around puberty, which means that germ cell loss precedes the onset of fibrosis. And this is an important finding, because this means that it is not a fibrotic process that causes the germ cell loss. It must be something else. But what could this be? Maybe it is the karyotype of the germ cells themselves. So in the next study, we wanted to analyze the karyotype of the germ cells, but also the somatic cells, the Sertoli cells, peritubular myoid cells, and the Leydig cells. So first I want to explain X inactivation. So in females, all cells have 2 X chromosomes, of which one is silenced and becomes the inactive X. In males, there is only one X chromosome, and that is an active one. And in Klinefelter patients, they also have 2 X chromosomes, of which one is inactive. Now, how does X inactivation occur? Well, cyst mRNA is transcribed from one X chromosome and binds to the entire surface of the other X chromosome, and that X chromosome becomes inactive. Now, next to cyst, also histone modifications play a role in the process, and one of these modifications is H3K27 trimethylation. So we performed a staining for this histone modification to check for the presence of inactive X chromosomes. So let's start with the germ cells. We saw that the spermatogonia, all spermatogonia in fact, lacked this histone modification, which means that there is no inactive X chromosome present, implying that these germ cells only have one X chromosome. And this was confirmed by fish, where we detected only one signal for the X chromosome. We also checked the Sertoli cells. And the Sertoli cells that are present in tubules with spermatogonia also seem to lack this histone modification, implying that also these Sertoli cells have only one X chromosome. But if we have a look to the tubules without germ cells, so the Sertoli cell only tubules, then we could find tubules with Sertoli cells that are negative for this histone modification, but also tubules that have Sertoli cells that are positive for this histone modification. So it seems that the Sertoli cell only tubules can either have Sertoli cells with one X chromosome or Sertoli cells with 2 X chromosomes. And for the other somatic cells, the peritubular myoid cells and the Leydig cells, these are either negative or positive for the histone modification, which shows that these cells are mosaic. And this is independent of the presence or absence of germ cells in the nearby tubules. So to end this talk, we find 2 types of tubules, the tubules with euploid Sertoli cells and tubules with aneuploid Sertoli cells, or a mix of both. Spermatogonia are only found in tubules with euploid Sertoli cells, and these spermatogonia are also euploid. The interstitial cells are mosaic. So therefore, we think that spermatogonia and Sertoli cells have to lose the second X chromosome, and then focal spermatogenesis in that tubule is possible. Otherwise, the germ cells will die. And with this message, I want to end this talk. I want to thank my team members, and especially Doreen, Margot, and Semir, who have performed most of the work I presented today, but also the clinicians from the Fertility Lab and from the Klinefelter Clinic. And I thank you for attending.
Thank you so much for all of you for joining us. And we are open for any questions if you would like. Seems like everybody answered all of the questions. I'll give it just a minute here in the chat in case anybody is entering anything. All right. Mahmoud, do you have anything to add?
Thank you so much for this great webinar. Really, we are very happy to have great experts like you with us today. Maybe you can, Courtney, wait for more questions if somebody wants to answer.
Sure.
I actually have a question. I finally managed to find my camera. So for Ellen, with your X inactivation study, do you know if there was actually a loss of the second X chromosome, or there was a problem with inactivation? So have you looked for, like with fish probes, for 2 X chromosomes?
Yes, we always confirmed our immunohistochemistry data with fish on a selected number of cells, but indeed in these cells we only found one X chromosome.
And typically the patients are also mosaics, or?
No, we only selected patients that were diagnosed as non-mosaic, but of course this is tested on only 20 lymphocytes, so it might be that these patients are mosaic in other tissues. The mosaicism in blood does not say anything about the mosaicism in another organ. But we selected them based on their they were diagnosed as non-mosaic Klinefelter patients. Yeah.
I have one more question. So I studied meiosis. So having 2 X's and Y is not good for chromosome synapses and segregation. So I wonder if some of the sort of testicular problems could be treated with spermatogonial stem cell transplantations. I don't know the field with Klinefelter, if that has been tried or considered.
Well, in Klinefelter, it will be very hard to do that because the testes are very sclerotic and firm when they are adults. So the
younger, I know it's
at younger age, yeah. It's always difficult to do these transplantations at younger age because you don't know if they really will be infertile.
But I'm thinking more like retrieving sperm. Even like we can probably be able to do things in a dish with cultured spermatogonia, put back.
To culture spermatogonia, you need, of course, a certain amount of spermatogonia, and the patients that we saw really didn't have a lot of spermatogonia. I guess it will be very difficult to do that.
Cool. Thank you.
I see your question in the chat, but why don't you go ahead and we have a small group, so go ahead and Dr. Silber.
I was just wondering, there seem to be plenty of prepubertal SSCs in the early infant from what you showed. Can we, with Tessa, take these stem cells, freeze them, and then when they're an adult, do you think these prepubertal germ cells, which disappeared as the baby grew into an adult, could they then be injected, do you think, into the adult through the Reedy testis injection and actually function?
Well, as I said, transplantation in adulthood is, I think, very difficult because the testis is very sclerotic. Most of the tubules are hyalinized, so I don't think they will be able to harbor the spermatogonial stem cells and support them to produce sperm cells.
So if that were to work, it would be most likely an in vitro maturation of those germ cells, right? If that were possible, I know.
Yeah.
And that's wondering if they could even work that way by in vitro maturation of some sort. In other words, are they destined to die, or are they just dying off because of the tubular problem?
Well, as we see, first the germ cells disappearing and then the onset of fibrosis, I would think that it's a problem of the karyotype. If they are not able to lose the second X chromosome, I think that they just can't survive. And also if the Sertoli cells that need to support the germ cells don't have a normal karyotype, they will not be able to support the survival of the germ cells neither.
Got it. So that's not really viable if they're if they've got, if they're XXY, they're destined to die if they don't lose that extra X chromosome. Yeah.
Yeah,
Okay.
that's what we think. Yeah.
Okay.
Okay. Well, thank
I
you so
also
much.
have a question
Yeah.
to Claus about the testosterone replacement. Do you think testosterone replacement during puberty is beneficial for the spermatogenesis?
Mhm.
No, I don't think it's beneficial for the spermatogenesis, but I think it's beneficial for a lot of other outcomes. And we are actually starting a national trial in Denmark. We just got money for it, where we are going to start early on, around 12 years, and then in a later group when they fail, so to speak, and become hypogonadal, only then to replace testosterone. And there we're going to both study, of course, body composition and stuff like that, but also neurocognitive development, which is one of the big issues in adulthood. And I think that testosterone may have an effect there, but I mean the Davis study on newborns and so on didn't really convince us that it will help on neurocognition. So I don't know. But we'll see. It's I think that's perhaps the overarching issue in adulthood, apart from infertility, of course, that the neurocognitive development, many of the males that I see have great problems with that.
I think it's such a huge concern among the parents of the adolescents too, that I think that 12 and up range is it's just we're just desperate for more information, because these kids they struggle in school, they struggle with friends, they you know, and parents all want to give testosterone to fix that. And it's you know, they think it's going to be the magic bullet, and certainly if it's going to help, we'd love, you know, that would be great, but I am concerned that's not certainly not the only answer.
No, and it's not likely that, because we know from these MRI studies that there really are differences in the brain, and testosterone is not likely to fix that. So yeah.
That brings up another question that relates to the genetics talk you gave. And we were puzzled when I was with the Page Lab with intrinsic differences between men and women, maybe not related to hormones, because despite X inactivation and X hyper expression, which is supposed to make the female's 2 X chromosomes no worse than the male's 1 X chromosome. But then there are the X chromosome escapers, and I guess there's hundreds of those. So the last I left the David Page Lab, they were trying to figure out whether those X escapers led to hyperexpression and therefore differences between men and women, disease prone, that were not just related to hormonal differences. And I don't know where they've gotten with that. And I don't, since you studied this, maybe you know where they are, and I've been out of that field for a while. But I'm wondering if that can also just relate, as you're saying, to the Klinefelters, that there are these escapers that make it different for XXY and XY.
Well, we don't know yet, but as we see it now, we see Turner's and Klinefelters in the kind of like they have mirror expression of all these PAR1 genes, of all these XY homologs, and also when it comes to methylation, the epigenetic marks and so on, there seems to be a mirror. So Turners are generally hypomethylated, not only in blood, but also in muscle and fat. And Klinefelters are hypermethylated. And this likely affects, we can see that affects not only the X chromosomal genes, but it also affects the autosomal genes. So the story of genetics and genomics in Turner and Klinefelter is really becoming so much more complicated, and you could say also interesting, because it's intriguing how this works. So it's likely that we see a little let's say some gene that is overexpressed just to a little extent or underexpressed compared to normal males and females. But since it's over or underexpressed for their entire life, it may well play an important role in regulating this or that. And so I think we are going to end up with having subtle differences in many genes that are likely to affect what we talked about, testicular function, but also brain function and other parts of all the traits that we see in these syndromes. But this is just my thinking, and I don't know if we're going there or if something else is going to show up.
Yeah, I get it. It
Yeah.
seems like good theory, speculation. I just didn't know if there was any solid data coming up yet. Yeah.
But there are data coming out, as I said, and also from the Page Lab in Boston and so on, but also from other people, and we more or less find similar findings, but it's we're still missing a lot of bits and pieces to put it all together.
Yeah. Thank you.
All
Okay.
right.
Well,
We will wrap it up.
Yeah.
And I know this will be available on the Oncofertility website as well as recorded. So if you need to go back and look at anything, it will be there as well. And I know we have lots of viewers that way who can't attend in real time. So thank you so much to our other speakers, and everybody have a good day.
bye-bye.
Thank you.
Bye-bye.
Thank you.
Thank you.